Hello, I'm Dr. Adam Martin, pharmacist and certified personal trainer from the American College of Sports Medicine, presenting on diabetes and non-prescription products, opportunities for pharmacist intervention on behalf of Dr. Scott Drab from the University of Pittsburgh School of Pharmacy. I have no conflicts of interest in providing this presentation. Today I'll be talking with you about diabetes and non-prescription products, opportunities for pharmacist intervention. In the United States, 1 in 3 people today will develop diabetes in their lifetime. Of the more than 29 million Americans believed to have diabetes, 1/3 of people with diabetes are undiagnosed. Many of the patients with diabetes maintain poor glycemic control. Less than 2% receive optimal quality of care, and only about 1/3 receive education about the disease. These reasons and statistics are why we as pharmacists have opportunity to make an impact in these patients' lives. For pharmacist involvement, patient identification, specifically high-risk patients, due to the rapidly increasing incidence of the disease, screening will be cost-effective. Patient assessment via questionnaires, education following diagnosis, providing in-depth information, continuing education to reinforce concepts, patient referral, and monitoring care, counseling from the pharmacist, and product recommendation are all opportunities we have in the profession to help these patients. So, what products are appropriate for patients with diabetes? Let's look at aspirin first. A lot of people think that aspirin is okay, so just take it. Not quite. Patients with diabetes have a 2- to 4-fold risk of dying from complications stemming from cardiovascular disease. Treatment ranging between 75 to 162 milligrams daily reduces risk for MI, myocardial infarction, stroke, and other cardiovascular events as primary and secondary prevention. Now, what are the guidelines for recommending and taking aspirin? From the American Diabetes Association, primary prevention is to consider aspirin therapy, 75 to 162 milligrams a day, as a primary prevention strategy in those with type 1 or 2 diabetes. An increased cardiovascular risk, having a 10-year risk greater than 10%, including most men or women with diabetes aged 50 years or greater with at least one additional of these risk factors: family history of premature atherosclerotic cardiovascular disease, hypertension, smoking, dyslipidemia, albuminuria, not at an increased bleeding risk. Now, what are the precautions for these recommendations? Aspirin should not be recommended for atherosclerotic cardiovascular disease prevention for adults with diabetes at low atherosclerotic CVD risk, having a 10-year atherosclerotic CVD risk less than 5%. Examples of this include men or women with diabetes aged less than 50 years with no major additional atherosclerotic CVD risk potential. The potential adverse effects from bleeding likely offset the potential benefits, which is why we would not recommend it. Also with the precautions are with patients with diabetes less than 50 years of age with multiple other risk factors, like a 10-year risk of 5 to 10%. Clinical judgment is required on behalf of the healthcare professional and the patient. Use aspirin therapy, again ranging between 75 and 162 milligrams per day, as a secondary prevention strategy in those patients with diabetes and a history of atherosclerotic CVD. For patients with atherosclerotic CVD and documented aspirin allergy, clopidogrel, brand name Plavix, of 75 milligrams a day should be used in its place. Dual antiplatelet therapy, reasonable for up to a year after an acute coronary syndrome. Now, what about hypoglycemic episodes? Let's talk about when blood sugar gets too low. 3 categories exist for this: mild, moderate, and severe. Let's take a look at which each is. For a mild hypoglycemic episode, that is characterized by sweating, shaking, hunger, feelings of anxiousness, and weakness. If you escalate that further, it becomes moderate, seen by confusion, poor coordination, loss of concentration, glassy eyes, slurred speech. And then there's severe hypoglycemic episode, characterized by unresponsiveness, agitation, convulsions, and even unconsciousness. Now let's look at how to treat that. The treatment of hypoglycemic episodes goes by the 15-15-15 rule. For mild to moderate hypoglycemia, glucose of 15 grams is the therapy. Repeat that every 15 minutes if the blood glucose shows to be continued high. Then have a small smack once euglycemic or once blood sugar returns to normal. In case of severe hypoglycemic episode, you will need a glucagon administration and medical assistance. Tips on treating hypoglycemia. All glucose tablets must have the same glucose content. 3 to 4 glucose tablets equal 1 tube of glucose. So there are a lot of options for patients. There's the gels, there's the liquids, there's the tablets, and there's the gel. We want to make sure that patients understand what the equivalent is from one product to another so that they make the appropriate choice. Tablets are more appropriate for mild hypoglycemia, and gel is better for moderate, as the patient may have difficulty swallowing by the increased severity of hypoglycemia. Now let's look at glucagon, used for the administration to treat severe hypoglycemic episodes. All patients with diabetes, type 1 and 2, should have a glucagon emergency kit to treat severe hypoglycemia with loss of consciousness or inability to swallow. Tips for patients receiving this, if you're the pharmacist giving this to your patient, would be to instruct the patient's family and friends on proper reconstitution administration. As, of course, it's great to educate the patient, but as they're the ones that will be unconscious, it's best to have those that are going to be around them at this time know so that they are comfortable to give this to help their family member or friend. One big thing that pharmacists need to know is this needs to be reconstituted. So there are, in the picture here, there's a vial and a pre-filled pen that needs to be mixed. So the pen is injected into the vial, shaken, and then drawn back up in the syringe for administration. That is a big point that most people are not aware of. And what's really helpful is on the inside of the red box for the glucagon kit is a diagram showing you, picture very simple to understand, because at times like this, patients and or family members, well, the family members that are giving it are going to probably be very unsettled and nervous. So having them as simple instructions as they can be, laid out in picture format, will help get this message across. First step, when the patient is unconscious giving this, is having them turn over on their side, as after giving this there is a tendency to vomit, and this will prevent complications if that were to occur. Now let's look at nutritional supplements for patients with diabetes. Meal replacement shakes and bars contain slowly digestible carbohydrates and provide a balanced meal alternative, preventing that sharp glucose spike that can be seen with simple sugar foods. A unique blend of slowly digestible carbohydrates produces a lower blood glucose response, minimizing this glucose spike that I had just mentioned. Here are some pictures of products available on the market today. Boost has a glucose control product, and then of course Glucerna is the very popular line for these products. Extended action carbohydrate snacks. The duration of action can last over 8 hours. This is variable, however, and there is a graph here in the slide to show you that exact concept. The ideal prevention is to keep the hypoglycemia low overnight, which shows in this graph here. The Extend bar has about roughly 8-hour action to keep the blood glucose away from hypoglycemia, so a little higher, and that'll show you from the time eating on the x-axis, it goes over to just over 8 hours, compared to, in blue, the typical carbohydrate snack that gives you a quick glucose spike and then is gone out of the system in roughly 2 hours. Now let's look at foot care. We all see that diabetes can, over time, cause loss of sensation in the feet, so it's extremely important to look at the feet. If you have, let's say, like a little nephew that plays with cars and leaves the car in your shoe, for an average person that doesn't have diabetes and no loss of sensation, they'll put their foot in the shoe and they'll be like, oh, what's this? They'll take it right out. But for a person with diabetes, they're at risk of loss of sensation and might not even realize that there's a car in the shoe. Take that like over an hour, a couple hours, and that friction of the shoe on the foot can cause bruising, puncture, and if that goes unnoticed, leads to infection and later amputation. This does happen. It's not that crazy. It actually is something that happens on a regular basis, so that's why discussing proper foot care with your patient is so essential. Ulcers and amputations are a major cause of morbidity and disability and carry many physical and emotional costs, actually 15 times more common in patients with diabetes compared to those without. So that's just a little story to show you what can happen for someone that doesn't have that sensation. Patients with diabetes are at increased risk in the following situations: history of foot ulcer, amputation, foot deformities, peripheral neuropathy with LOPS, preulcerative callus or corns, PAD, poor glycemic control, visual impairment, diabetic nephropathy, especially dialysis patients, and cigarette smoking. These further increase the risk for foot ulcers and amputations. Now let's look at how the foot problem has evolved over time. In patients with diabetes, there's a threefold problem that occurs. It starts with neuropathy, peripheral and autonomic. Autonomic changes, that becomes decreased perspiration, cracks and fissures can form in the foot. That can lead to angiopathy. Micro and macrovascular changes occur, leading to reduced circulation and healing. Finally, it leads to the third step, which is immunopathy, impaired cellular and hormonal activity leading to a decreased immune response. The above culminated increased risk for ulcers and infection in patients with diabetes, which is why it's so important for us as pharmacists and healthcare professionals to have these conversations with our patients to prevent them from having these undue risks. The key takeaway is that prevention is crucial. It's been said an ounce of prevention is worth a pound of cure, and that is so true with foot care in diabetic patients. They should be educated to inspect their bodies daily, looking for signs specifically of dry, cracked skin, areas of chafing and irritation, deformities, and signs of infection and ulceration. Daily application of moisturizing creams is critically important to prevent the dryness that leads to cracks and fissure. Cream should be applied to all dry areas, but not between the toes, because that can lead to a fungal infection. Moisturizing agents versus hydrating agents. Here we have two common products that patients can use. We have the Eucerin Original Healing, and then we have the Nivea Hydrating Agent. We really want to emphasize daily care, especially when patients get out of the shower. Dry themselves, place the lotion on the feet and other areas of the body, to create a ritual or habit that patients can get into to practice healthy habits. Patients with neuropathy should wear well-fitting walking or athletic shoes. Break them in slowly. When you buy a new pair of shoes, don't plan on going for a 20-mile hike. That will cause problems. Please ease into them, wearing them just walking around the house first, and then slowly using them more often for longer periods of time. This will allow the foot to adapt to the new shoe, and over time will become more comfortable. Socks should be breathable, soft spun cotton with seamless toes to avoid irritation. Avoid tight elastic socks that may restrict circulation, and keep nails well trimmed and maintained to the contour of the toe. This will prevent ingrown toenails and unnecessary cuts. Now, a patient may come to you hearing all this information from either their physician or you and say, okay, what do I need to buy? So let's go over foot care supplies for a diabetic patient. Some essential go-tos could be a pumice stone, foot file, a nail care kit to keep the nails trimmed as we just discussed, antifungal creams, dry skin creams, and antibiotic creams. The best place to get this list would be from your local pharmacist. Alcohol swabs. Remind patients to swab insulin vials before use. This will prevent any potential contamination from storage or transfer from where the medication was to in their hand. Generally, patients should not swab the skin with alcohol, which is a very common misconception. It's usually unnecessary in those practicing good hygiene. It increases the skin at risk for dryness, and it may dilute blood samples during glucose testing. Now let's talk about self-monitoring of blood pressure. Home blood pressure self-monitoring and 24-hour ambulatory blood pressure monitoring may provide evidence of white coat hypertension, masked hypertension, or even discrepancies between office and true blood pressure. Home measurements may better correlate with atherosclerotic cardiovascular disease risk than in the office, as it bypasses this white coat effect or bias that artificially inflates the true blood pressure that the patient has. As we know, hypertension is a major risk factor for CVD and macro-microvascular complications. Atherosclerotic cardiovascular disease is the leading cause of morbidity and mortality for diabetic patients. Effects of blood pressure and blood glucose on microvascular complications are independent and additive. Blood pressure greater than 115/75 is associated with increased cardiovascular event rates and mortality in diabetic patients. Pharmacists should encourage their patients to monitor blood pressure in conjunction with blood glucose. Considerations for blood pressure monitors. A patient may come to your pharmacy and say, "Which blood pressure monitor?" If you go and look with them, there's a huge myriad. Sometimes it reminds you of Costco. So it's very important to have that relationship with your patient and see what their specific needs and goals are. Some of these patient-specific consideration factors would be the patient's visual acuity, manual dexterity, patient support network, patient's preference, cost, and then the types. There's the manual versus the automatic, and then there's the arm, wrist, and finger that we'll look at now. Manual versus automatic. Prices have changed dramatically in the past few years. It used to be that manual was far less cheaper than automatic, but today that is not the case. A manual blood pressure cuff costs less than an automatic, which is around $35. The price disparity used to be 3, even 4 times as much, but with advancements in technology and time, the price has lessened so that more patients have more access to easier using blood pressure monitors, the automatic, that run roughly $35 and up, depending on the model and all the other bells and whistles that it can contain. Manual may be difficult for some patients to operate without assistance. Accuracy of a manual monitor is more dependent on patient technique, which has more room for error, which is why getting an automatic blood pressure cuff for home use is so essential, as they may be self-inflating and often have large digital displays with memory capability, which is great for seniors and patients with visual acuity issues. Now, looking at other considerations for selecting a blood pressure monitor, we were going to look at the wrist option. It's compact, automatic, and easy to use. Again, the price disparity has lessened greatly and over the years. It used to be a more of a luxury type style, so the prices were around $50 and up. They've actually dropped substantially down to about $28 and up. There is concern over variability in the readings. A lot of the packages will say that they are as consistent with the wrist, but the wrist is as consistent with the traditional arm style, but it's still preferred as the mode. Looking at the finger blood pressure monitor, it is the simplest to use. It may be more sensitive to changes in position and temperature, so if there's fluctuations like today in Pittsburgh, it's 8 degrees. But in the summer, it can get up to 90 degrees, so the fluctuation of the environment can affect the reading. Also, if the patient was going on a long walk and took that, that can also affect it more so than it would a traditional blood pressure reading. It does have an increased cost, as it starts at $80, which is substantially higher than other blood pressure cuffs available. And the claims of accuracy may vary from patient to patient. There is a lot of variability with that. Now that we've talked about blood pressure monitoring, let's look at vitamins and herbal supplements and glycemic control. 30 to 70% of diabetic patients use some form of alternative medicine over the course of a year. That is a lot, and that is a huge opportunity for pharmacists to help the patients make an appropriate selection to prevent unwanted side effects, cost, and serious health concerns. The most common vitamin supplements that diabetic patients are taking is what we'll look at now. The first is ginseng. It has a decreased rate of carbohydrate absorption into hepatic circulation. It increases the glycogen storage and modulates insulin secretion. A lot of times you'll see it used for brain health as well, but in this case it actually can be utilized for sugar or diabetes impact in addition to that. Niacin is the most effective in raising HDL cholesterol. It may increase blood glucose at high doses due to increased insulin resistance. So this is something to keep in mind as a side effect, in addition to the common flushing that we see with this over-the-counter modality. ALA, or alpha-lipoic acid, is an antioxidant in water and fat. It may enhance glucose uptake in muscle, and it's used in treating peripheral and autonomic neuropathy. Now, there are a lot of other supplements and herbal options that patients can take for diabetes, and rather than go through them, I've categorized them into two categories: hypoglycemic agents and insulin sensitizers. Looking at hypoglycemic agents, there are a lot of odd ones, or things you might not be familiar with, that I placed here just so that you are familiar. If a patient were to come to your pharmacy and ask, or call your pharmacy and ask what your thoughts were about it, the most common that you would see from this list would be fenugreek. So that is a hypoglycemic agent. The second list is insulin sensitizers. The most common that's caught a lot of media attention in the past few years is cinnamon. That's not to say that taking a quarter teaspoon with your tea is going to cure your diabetes. It does have an impact, however, it's at larger doses. Therapeutic impact is said to be around 3 grams worth of cinnamon. There are differences as well versus using cinnamon that is in your spice rack in your mom's cupboard versus cinnamon extract. So there is a lot of variability with that, and there's not really a consistent dosing. So it really depends on the individual product you're looking at, which is why you want to consult with your pharmacist and your patient. Chromium and magnesium are also common agents that we see patients taking and asking about. And then there is another one, berberine, which goes by several different names that I listed here so that you are able to be familiar with them. And that's golden seal, gold thread, Oregon grape, and turmeric. Two other classes that I grouped for you. One is more of a section, and the other is more miscellaneous, grouping that. Carbohydrate absorption inhibitors. This kind of blocks the absorption of nutrients from the diet. So that would be white mulberry, and then also the soluble fibers. So this would be like what you would see in your upset stomach aisle in your pharmacy. So that would be like psyllium husk, guar gum, oat bran, flaxseed, and then the insoluble fibers, which is rough and coarse. You can think of that as like roughage to kind of get things to go. And then examples of that would be soy and glucomannan. And then I also grouped the miscellaneous products so that you're familiar with these should patients ask you. These do have applications with diabetes. I want to make sure you're aware of them. Coenzyme Q10 or CoQ10, commonly taken by patients on statin therapy. Stevia, selenium, and shea. One of the big supplements that has been used for a long time is chromium, and that is naturally occurring in the body, required for glucose metabolism. So the thought behind this is if you take more, it will speed up or improve the metabolism of glucose. That's the thought. Deficiency associated with impaired glucose tolerance. Most patients with diabetes are not chromium deficient, so a lot of times we hear that if you take a supplement, it will help you if you're deficient, but if you're not, it won't really make a difference depending on it. That's kind of the thought behind this recommendation. And it's important to point out that diabetic patients aren't at an increased risk for that. Most of them are fine with their level of chromium, so there shouldn't be a need to supplement with that. Proposed mechanisms for how this work is increased number of insulin receptors and also potentiation of insulin's action. The common form that chromium is sold is chromium picolinate. That decreases fasting and postprandial blood glucose, decreases fatigue, and decreases polydipsia and polyuria. Looking at the vitamins and herbal supplements as a whole, there is no supplement that has sufficient evidence to support or discourage its use in patients with diabetes. Most appear to be generally safe. However, that's not an assumption across the board, which is important why we as pharmacists need to communicate and have a good relationship with our diabetic patients so they can come to us with their concerns and we can help them make the appropriate selection. Low-risk patients usually meet their nutritional requirements from food sources. However, it is important to make sure all the bases are covered, which is where nutrition comes into play. Elderly and vegetarians may benefit from multivitamins. as it's hard to get the full spectrum of vitamins and minerals on a restrictive diet. Smoking cessation. Smoking is the most modifiable cause of premature death. That is a fact. And we as pharmacists know that we are the most accessible professionals in healthcare, and we can use this to make an impact on our patients' lives, especially our diabetic patients' lives. Patients with diabetes are already at a heightened risk for cardiovascular disease, premature death, and microvascular complications. Smoking cessation should be considered a routine component of diabetes care, as this can have a profound impact on our patients' health. It's modifiable, they can control it, so we as healthcare professionals, we need to discuss with them if they are ready for change and go through those steps to help them make the appropriate decisions. Looking at what's available for patients to help them quit smoking, as we are aware, it is very difficult to just quit. There are products available to help our patients. There is the nicotine replacement gum, or Nicorette. Advantages for that is it prevents a rescue solution for acute cravings. It's easy to control the dose and timing, and that is very helpful because you don't have to draw a syringe or anything like that. It's just one little tablet that you can take if you get a craving. You can carry it in your pocket. It's very easy to use, and it's very versatile. Some disadvantages is that improper use can cause some serious side effects. If someone chews the gum like regular chewing gum, rather than chewing and parking, it'll cause extreme nausea and even vomiting. So it's important to talk with your patient on how to use this product properly. It can have a poor taste, and it can be difficult for patients with dentures. Also, cost can be a concern. There's also the patch option for patients looking to quit smoking. Nicoderm CQ is the popular product here. Advantage with this is they don't have to take it every hour. It's kind of stick it and leave it, good to go. If it's worn overnight, it may reduce morning cravings. It does provide a baseline level of nicotine to keep that kind of basal control of cravings through time. But you can use it with the gum for those acute cravings that we've discussed. Some disadvantages is that it has minimal control, the patient has minimal control over the dosing time of delivery. Also, cost can be a concern. One of the other side effects of this product is vivid dreams. That's not to say nightmares, just very vivid. Some patients actually prefer it because it's like they're living an alternate reality when they sleep. It is something to discuss with your patient so that they aren't startled if they were to discover it and weren't aware. But again, it doesn't cause nightmares, just vivid dreams, so it isn't an odd side effect with this product in particular. The other option is nicotine lozenges. Advantages for this is that there's quick action to quell cravings, similar to as we discussed in the gum. It's simpler to use than the gum, however. It is easy to control the dosing and timing similar to the gum, and it's more complete nicotine delivery than the gum. So it has the same benefits that the gum has, and then some. So it is a more versatile product, and it adds more advantages, but it's something to discuss with your patient based on their preference. The disadvantages is it is more costly. Looking at self-monitoring of blood glucose, patients who monitor blood glucose levels regularly are more likely to reach their goal. It's kind of like keeping your eye on the ball. If it's always on it, you're going to notice fluctuations and make action steps in order to make those improvements. But if you don't look at it consistently and it's haphazard, you're less likely to make the changes needed to get to your goal. As patients who do not monitor it have more irregularity and are less likely to reach the goal of blood glucose control. Here in this chart here, we see comparison of type 1, type 2, insulin-dependent oral agents used, and then diet controlled. So we have no utilization at all. We have less than daily utilization of self-monitoring of blood glucose daily and at least 3 times a day. So if you look at the graph, it's very nice at depicting the patients that spend more time looking at their blood glucose on a consistent basis have greater control in reference to their A1C levels than those who do it infrequently or not at all. So what are the benefits of a patient monitoring their blood glucose? They gain immediate access to information. There's no delay at going to the doctor's office and waiting to hear back. You have it right in the palm of your hand. It encourages patients to become involved with their own management. It increases patient motivation to keep blood glucose within target range. You can identify and correlate symptoms of hyperglycemia and hypoglycemia with blood glucose values. It connects patients to their own blood glucose level. It provides data necessary to adjust therapy, and it reduces a patient dependence on healthcare professionals. So let's look at the diabetes report card. I'm willing to bet that it's not an A+, and I think you can agree with me. Percentage of United States adults age 18 or older with diagnosed diabetes who reported receiving recommended preventative care practices from a 2012 statistic states that only 63.5% of Americans with diabetes measure their blood glucose levels. Looking at all the benefits we just talked about that patients can gain from monitoring their blood glucose, and then seeing that the overwhelming majority do not, has a huge disparity and opportunity for us as pharmacists to talk with our patients about the importance and benefits that this practice can have on managing their diabetes and improving their overall health. A lot of patients don't do self-monitoring of blood glucose, close to 2/3, and there are some reasons why that can prevent barriers. That would be pain from pricking their finger, time involved of doing it, the convenience, recording issues, lack of understanding as technology can overwhelm many patients, the expense, as we know test strips are very expensive without insurance. There is emotion, depression, discouraged, feeling hopeless, and then there is a poor support network for a lot of patients. Family healthcare provider, their family might not understand or have the desire to help them with that. Their healthcare provider, they may feel, is too busy to help them, or doesn't really want to spend the time. They can feel like they're a nuisance, and that can play into the emotional impact that that has. So these are some of the reasons why patients do not, and why that number is so high, close to 2/3. How to overcome them? Let's first look at the number one reason patients don't like to test: pain from testing. Pain is related to the sample size of blood drawn, the site that they draw their blood from, the lancing device, and the lancet itself. The sample size has decreased dramatically over the years. It used to be blood would be about 10 microliters in size, seen on the picture in the slide here, a very large drop of blood. However, now with the Freestyle meter, you only need 1/3 microliter. That's 30 times smaller. So that's a huge difference. Less blood, less pain, more ease for the patient to do this practice without having pain as a barrier. Here are some other meters. There's the Accu-Chek Aviva, there's the Freestyle, and the Accu-Chek uses approximately 0.6 microliters of blood, whereas the Freestyle has the smallest current sample size required for testing, which is only 0.3 microliters. The other thing is that patients don't like to prick their finger, either because repeated use of the same site, which causes even more pain, or unsightly. A lot of patients are very conscious about their look and their view of fingers having that pricking site in testing. The good news is there is alternative sites on the body to perform self-monitoring of blood glucose testing. However, there are times when the fingertip testing is preferred. Looking at the chart on the body, we have highlighted the other spots on the body where patients can test. The suggested testing areas for the hand are under the palm, the fingertips, and the side of the thumb. A very important thing that I have found with patients when talking with them saying that they won't test because the pain is so great, I will have them perform a finger prick. And when they do it in the middle of their finger, which is the reason why they're experiencing so much pain. All of the nerve endings on your hands end right at the fingertips. If they just shift that just not even half an inch to the side, they will experience far less pain. So if you do have patients that are saying they have pain with testing on the fingers, ask them where they're testing or have them do the testing in front of you. And more often than not, I find that it's in the middle. So if you just recommend they do it to the side of their finger, that will cause a lot less pain and help the patient continue to monitor their blood glucose. The reason that we do prefer the finger is it's consistent. There are other options for the patient to test, as seen on this chart that we discussed. However, rapidly changing glucose levels may cause alternate sites tests to differ significantly from fingertip samples. So if they were to take a finger prick and then an alternate site, they may see some variability, and this is the reason why. And like I just said on testing with the fingers, here's a diagram to show you all of the nerve endings in the finger are right at the center. So if they were to shift to the outside of their finger, that is one of the biggest key counseling points I can offer you for your patients looking to monitor their blood glucose. That will significantly reduce pain, which will increase compliance to testing, which, as we know, will increase their goals with staying in range and lead to a lower A1C. As we discussed, there is variance in the finger site testing with alternate site testing. A practice that can reduce this variability is called arm rubbing. In many patients, vigorously rubbing the arm eliminates the glucose difference between the arm and the finger. And here's a chart to show you that. Arm not rubbed, they take the glucose sample of the arm versus the finger, and you see that there is a pretty wide variance in between the blood glucose values between the two testing sites. However, when they compared that to rubbing the patient's arm, as depicted in the top left slide. Okay, so if we're looking at those two graphs, in the top left, the patient just rubs their arm very simply like so, and then when they tested the blood sugar in that area and compared it with the finger, as seen in the graph on the right, the variability between the site testing at the arm and the finger was greatly reduced, and it's very linear compared to the graph on the left when a patient did not rub their arm. So this is a practice that a patient can do to reduce that variability. Tips regarding alternate site testing for your patients. When blood glucose levels are falling, fingertip testing may identify hypoglycemic episodes quicker than alternate site testing. Fingertip testing when individuals are concerned about hypoglycemic reactions is the preferred site of testing. Alternate site testing can be used testing prior to more than 2 hours after meals, insulin doses, or physical exercise. It's recommended to use fingertip testing within 2 hours after meals, an insulin dose, or physical exercise. The lancing device is another thing that can reduce pain for patients. Some options out there had an adjustable depth setting, and then also another thing to look at is the advancements over time with the lancing devices of having a straight motion unique to a cam-driven device, which minimizes pain, compared to the side-to-side motion that's seen in the picture B in the chart on the bottom, that causes the skin to tear or push apart. If it strikes the skin at an angle, it's a lot more likely to cause pain than when using a cam device, lancing device, where it's straight and minimizes pain because it's a simple in and out puncture rather than a jagged motion. The quality of the lancet also has a huge play. Not only for safety and health concerns do we recommend patients never reuse a lancet, but also it decreases pain. Once it's used, it gets very dull. As we said, just for reducing the spread of disease and keeping hygiene at an optimal priority, in addition to that, if a patient were to reuse a lancet, say for cost, not only is it put them at risk for those problems, but it also will increase their risk for pain, which is why I recommend using a disposable lancet device. A new lancet is smooth, sharp, straight, precise grinding and polishing, and has a silicone coating at a beveled angle. A used lancet does not really have any of those qualities whatsoever, and it's not created equal. So a lot of times if patients get those cheaper alternatives, it might result in more pain, which has defects in the manufacturing process. So it's really recommended that patients select a quality product from trusted manufacturers. The size of the lancet can also have a play into the pain a patient experiences. Most lancing devices use the standard 25 gauge square end lancets. Ultrafine lancets do offer greater comfort than this. The One Touch Delica has a 30 or 33 gauge. The Soft Touch lancets have a 28. The One Touch Ultra Soft has a 28, and the BD Ultrafine range from 33, actually has 30 or 33 gauge. Lancet types, there are the single-use lancing devices like the Accu-Chek Safety Pro Plus, and then there's the safety lancets, which prevents accidental finger sticks. It's single-use, and an example of this would be the BD Genie lancet. Here's a picture of the Accu-Chek Safety Pro Plus. That's the single-use. Another barrier that we discussed with self-monitoring blood glucose is the time involved for patients to do the testing. New meters can improve this barrier and help patients with this issue. Compared to 45 seconds with older meters, the new meters can take as little as 5 seconds to use. Less time equals improved convenience and compliance, and is correlated with better glucose goals in relation to their A1C. Convenience is another issue that we can help patients get over. Features that we can look at are integrated versus traditional strips. Integrated lancing devices, there's no coding necessary on many of the meters, the meter care and cleaning, the smaller meters, and manufacturer support. This is a resource that a lot of goes unnoticed and unused by patients, but it's very comprehensive, it's very accessible, and for, I think, all of them, it's 24 hours a day, 7 days a week hotline that patients can call and have access to a trained healthcare representative that can guide them through any potential issues, frustrations, or just explaining how to use the device should the patient need that walkthrough. So it's a very good resource to talk with your patients that is on all the meters. Recording issues. A lot of times patients would get the bank statement booklets from their banks, not for money record purposes, but for writing down all the numbers. Over time, that gets more and more and more books. So patients would just see writing as an obstacle. However, that has been addressed with advancements in technology. Meters with expanded memories and data management software offers patients a very hands-off approach where they literally do their testing that takes 5 seconds and it's automatically recorded, a lot of times graphed, and printed out for the patient and their healthcare provider so they can identify trends in highs and lows with their blood glucose. This allows them to record insulin data, exercise levels, and carbohydrate amounts, all without the patient having to do any active participation, other than testing their blood sugar on a consistent basis. This provides, as we said, high and low readings averaged by time of the day, total average, standard deviation, and daily trends, which is helpful for the patient managing their blood glucose, or if they would like to work with a healthcare provider like their pharmacist or certified diabetes educator to look at these goals more in depth, that allows them to have this information as well. Looking back, we had said that in the olden days, before all the technology advancements we have, patients would handwrite their values out on either the bank books, the bank log books that we had said for like checking accounts, or pieces of paper. Here's an example of how it used to be. You'd see hard to read, you might not know the time, whether AM or PM, the day of the week, if there was a trend, and then you also have the blood spatter here, which could be a little unsightly for everyone. Data management software really changed that. So if we look back to the last slide, this is what we used to work with. This is what we have now. This, the patient would have to take the time to write it all out, make sure he got all the variables, write it down, and it can take a lot of time. This, the patient tests their blood sugar, 5 seconds, and without having to do this actively, all of this data and representation and presentation is laid out for the patient without them having to be an active participant in it. So it's really helpful to organize the data, because what good is data if you can't analyze it? That's the whole purpose of the meter. So that is what really allows ease of use for this training. Management software allows the frequency of testing to be documented with the time of day, how many times a day, the averages overall and the time of day, and also the standard deviation, a measure of glycemic variability, and then overall and time of day. The average, we want to be the standard deviation times 2, and that would be the average there for the blood glucose testing. Now let's look at 10 days of breakfast readings. Looking at the numbers at face value, it might look like one has better than the other, but this is what the importance of standard deviation plays in monitoring blood glucose. We look here at patient 1, Joe, has an A1C of 7%, a mean of 150, but a standard deviation of 94. Patient 2, Mary, has an A1C of 7%. Her mean is 150. So on these values, they're the exact same, but the standard deviation is 23. So who has the better control? Implications of a high standard deviation leads would be insulin deficiency, poor carbohydrate counting, missing a shot or injecting late, erratic snacking, gastroparesis, and erratic insulin absorption. So some questions to answer when analyzing a download of data that we saw with the sheets and the charts from blood glucose meter. Does the average match the A1C? If not, why is there a discrepancy? Is the glycemic variability reasonable? What are the standard deviations? Is the frequency sufficient at each time of the day for that patient? So these are some questions to keep in mind when looking at the data from a blood glucose monitor reading. Now, a very helpful thing is that the meters have become more compact and more technologically advanced. Now, with all of social media and smartphones being the mainstay for communication and just daily interaction, all that data has now gone to the mobile. So here we have the OneTouch Reveal mobile app that wirelessly connects with the OneTouch Vario Flex meter. So this literally gives you all the information and graphs at the palm of your hand, even reducing a step of having to print or analyze the data. It now is at the click of your thumb on the app. This allows some features with this app. It gives 14, 30, and 90-day summaries highlighting blood glucose patterns. It gives simple, colorful visuals to help get more meaning from the results. And it tracks progress with an electronic 12-month logbook. It allows you to share your blood glucose readings with your healthcare professional as well, enabling that communication to be established so that if an intervention needs to be made, it can be made even quicker. Let's look at patient Kevin Mitchell. He's a 28-year-old African-American male, banking executive, who has type 1 diabetes since age 16, recently placed on an insulin pump. He actively is involved in managing his diabetes. He has attended multiple diabetes education classes, and he tests very frequently. However, his fingertips are sore, he's very computer savvy, and he hates to write his readings in a logbook. So let's look at this subjective, objective data and the assessment. So for his subjective and objective, he's a type 1 pump patient. He's 28-year-old African-American male, banking executive that's computer savvy, actively involved in his care, insurance coverage is good, and he's a frequent tester. The assessment, based on what we learned in the previous slide, is that he needs a meter that meets his needs. He needs a small sample size to reduce pain, which is a barrier to him for testing. He needs alternate site testing to be an option should the pain become an issue. He needs an adjustable depth lancing device, possibly cam-driven, a large memory since he will be testing frequently in the monitor, downloadable capabilities as he is computer savvy, and programmable reminders to help him stay on track with his testing. So the plan would be to recommend an appropriate meter to meet Kevin's needs. Also, to demonstrate the meter to Kevin, pointing out key features. He is tech savvy, he's involved in his care, so he would probably benefit from going over things like the app features, going over downloadable features, going over all the tech savvy things that a meter provides that would catch his interest. So the important takeaway from this is to assess the patient, really get to know them as an individual, and then take all the knowledge we have as their healthcare provider and meet them where they're at. If it's a patient like Kevin that is really interested in technology, highlight those benefits of the meter so that it can pique his interest and keep him more engaged in his care. That's really the takeaway, is that each patient is an individual. We do have the information, but we need to cater that to the patient to help keep them on track with their health goals. Overcoming barriers, the other was a lack of understanding. Physicians can set glycemic goals and communicate them to their patients, and then they're often on their way. And that can leave patients feeling very overwhelmed, frustrated, hopeless, and just at a loss. The numbers, what do they even mean? What is a milligram per deciliter? It just doesn't really strike them. So it can really get a paralysis by analysis type of issue that we can overcome as their pharmacist. As their pharmacist, we can assist them in selecting their appropriate monitor by addressing visual challenges, their cognitive ability, the manual dexterity challenges of that patient in particular, and also slowed reaction time, the time to apply the sample. Also, as I said, we have to be sensitive to cultural issues in assisting patients. Every patient is different. Everyone has different histories, backgrounds, and goals. So as their pharmacist, having that relationship with the patient, it's important, as I said, to take the information we know, meet the patient where they're at, and align them so that we can help empower them to reach their health and fitness goals. Literacy, language skills, socioeconomic status, and traditional healing values are all issues to consider when communicating to your patient to help them feel more heard, also to establish that rapport and credibility to lead them to their health. Expense is another concern. The good news with this is they have come down a lot. Insurance coverage has expanded greatly. Test strips without insurance can range for a box of $100 to around $180, but with Medicare Part B insurance, that can be a zero copay. So there are a lot of benefits out there to help patients deal with the cost. One of the best resources for patients with diabetes is your pharmacist, because they know the products and they do have access to the insurance information. So we are a really good resource for diabetic patients who have this concern. So that's why it's so important to have this relationship with your patients, so that when these concerns come up, you can pick up on them and you can have the ability to address them and help break down the barriers so that they can get back on track with their care. Looking at history, in 1979, the Ames dextrometer cost $560. But like I just said, in current year 2016, most meters are covered by insurance or very little cost, being $20 or less. Again, looking at the expense, cash-paying patients need to evaluate the net costs of metered strips over time. Insurance patients need to review their copays and deductibles for diabetes-related items, and then also formulary considerations when a patient's selecting insurance plan, preferred versus covered meter system, and supplies. Again, the best resource for this information would be the pharmacist. Another barrier that has a huge play with diabetes patients and taking charge of their health with SMBG is the emotional factor. Discourage value judgments being good or bad. Use terms like in range or out of range. So what we're looking here is the language that you use with your patients can really have an effect. Even though you might not intend to be offensive, that can be interpreted by someone that's very emotional. They feel hopeless, they feel overwhelmed. So it's very important to be careful with the terminology you use when counseling your patients. Even if you go in from a mindset of you're trying to help them, you really need to be cognizant of the language that you're using so as not to offend the patient, and then they will totally shut down and not listen to what you have to say or just leave you entirely. So it's something really to be cognizant of when discussing with your patients. Poor support is another issue that some patients experience with managing their diabetes. Healthcare professionals must review SMBG data and provide useful feedback. So giving that support is really going to help their patients feel like they have someone in their corner to help them manage their diabetes. Useful feedback, immediate or near immediate, being simple or clear rather than overwhelming. So just breaking down the facts into very small, manageable bits of information so as not to overwhelm the patient. And then also stopping to assess, like, did you understand that? Did that make sense? Just ensuring comprehension on the patient's perspective. Promoting action rather than paralysis. So taking the action steps and breaking them into small, manageable steps that the patient can achieve. Invoking a sense of interpersonal engagement. And all of this feedback with the patient will stimulate an interest in obtaining more results. So if they see that they can achieve it, they will be more prone to do it rather than feeling overwhelmed and just throwing their hands up in disgust. So it really does help the patient empower themselves to take an active role in their health. Looking at a patient case, we have Grace Martinez, who's a 63-year-old Hispanic American. She was recently diagnosed type 2 6 months ago. She only speaks conversational English, minimal diabetes education, and is unsure of glucose goals. She has arthritis and poor vision. She's currently using a home remedy for treatment, and she feels guilty spending the family money on testing supplies. So breaking down what we just read about Grace into the subjective, assessment, and plan. The subjective plan and objective is that Grace is a type 2, 63-year-old Hispanic American woman who feels guilty about having the test. She has arthritis, so dexterity issues, poor eyesight, only speaks conversational English, not sure what is appropriate glucose control. Looking at the assessment, she needs a meter that meets her needs specifically. So that would be, some features that we want to focus on when helping Grace select a meter would be it needs to be large and easy to manage, even with arthritis. It has to have a large display. It's got to be easy to use and preferably require no coding as to eliminate a understanding or technology barrier. The cost of the meter and supplies must be affordable. The instructions should be in Spanish preferably to help with Grace's comfort, and also have access to a multilingual manufacturer support line. Should she have questions, she can communicate to someone in her preferred language about her frustrations or stomach blocks. She requires education on glucose goals, as well as discussion on her feelings of guilt in managing her condition. So the plan that we have set up for Grace based on this information would be first to recommend an appropriate meter to meet Grace's needs. Walk with the patient, show them the meter, take it out of the box, show them all of her concerns and how each feature of that particular meter is going to be specific to meeting her needs. Showing that level of care as the pharmacist is really going to make the difference in helping her to take an active role in her care. Second, we want to provide education regarding acceptable glucose range for both the fasting, 70 to 110, or the 2-hour postprandial, less than 140, for her goals. We want to set those goals specific to Grace. And then finally, we want to discuss her feelings of guilt and explain the need for her self-monitoring of blood glucose. And we also want to change that, so rather than feeling that she's a burden to her family members, we want to turn that around and involve her family members as a part of the discussion to show that they care, to show that she's not a burden, to show that they actually want her to take action with this. Hearing it from them will really help to dissuade this barrier. So future trends in self-monitoring of blood glucose. There are 1,440 minutes in a day. One blood glucose test represents only one point in time. As we said, meters have advanced over the years to now it takes 5 seconds to get a reading from a blood sample. So 5 seconds out of 1,440 minutes really puts that in perspective for a patient coming up with the barrier that there's not enough time. It really helped to set the stage and perspective that it is manageable and he or she can do this. With that, there is an option of continuous glucose monitoring. And there are some systems and products available for this, such as the Guardian RT Continuous Glucose Monitoring System. This sensor is inserted into the subcutaneous tissue of the patient. Levels are measured in the interstitial fluid every 10 seconds and recorded as an average over a 5-minute interval. 288 glucose measurements are taken each day. Readings are downloaded to a computer for analysis, so the patient doesn't have to worry about sitting down, taking these 288 measurements and going through them and dealing with the data. This is done for them. The indicated for use is for type 1 and 2 diabetic patients who are 18 years and older. The role of the pharmacist, looking at meter education, is going through the steps from taking the meter out of the box to putting it back in the box. What happens in between? The procedure for obtaining a blood sample, like we said, where to prick the finger in alternate site testing, which is indicated for each method, testing techniques for the site being used, the proper use of the meter, how to record the results. As we said, a lot of them are automatic with the meters, and the frequency of testing. This can be very specific to the individual, so that's why it's important to have the patient case and history at hand when discussing this information. Obtaining a sample, again, we looked at the graph before where we want to look at the side of the finger rather than the dead center. This is a huge counseling point that will really have an impact on your patient, so that's why I keep bringing it up. To reduce pain, using a new lancet for each one, as we said, not only for hygiene issues, but also because it dulls the lancet and you want that to be as sharp as possible to reduce pain. And then using warm water to clean the hands. Using warm water rather than cold is a benefit because it will increase blood flow, and cleaning the skin with alcohol, like a hand sanitizer, can dry out the skin, and as the diabetic patient is already at risk for skin issues, we don't want to add this on to their burden. Yeah, I didn't.